Julian is the vice president of communications at the VHHA, and they've been right in the middle of all of this stuff and trying to be sure that we can take care of our patients, those that are sick. And he's the vice president of communications of the Virginia Hospital and Healthcare Association. Julian Walker, great to have you, Julian.
Good morning, John. Thanks for having me. And I just have to say, you and I both have New Jersey roots, and listening to that Bon Jovi on the intro, that got me going and fired up for our conversation.
I tell you what, that was Kara's choice. We know you're from New Jersey. I was just talking to Nan Hayworth, and I was talking about how I used to visit my father. He used to be in the Army, so we'd always want to go to the West Point up there, and we dined together. And I would go up over remember the Tapansy Bridge at the end of the Garden State Parkway. You have to drive all the way up, so it's kind of fun. Anyway, Julian, VHHA, you've got 5,800 beds, 800 now COVID-19 people in the hospital. It seems to me, as an outsider looking in, that the Virginia Hospital and Healthcare Association has done a magnificent job so far in managing through this crisis. You want to elaborate on that?
Sure. Well, that's very kind of you to say, and really all the credit goes to our member hospitals and health systems and the tens of thousands of frontline healthcare providers, the doctors, the nurses, the first responders, the clinicians, all the folks that are providing direct patient care. All of the credit, all of the praise goes to them. But as you said, our members responded to this early and prepared and took some pretty aggressive steps to get ready for this. That includes the postponement of non-emergency elective procedures, which Governor Northam issued a directive on several weeks ago. But even prior to that, our members were taking that step to free up bed space, to enhance existing capacity so that they could accommodate the influx of new patients who are afflicted with COVID-19. Now, it's important to understand that occurred with some financial hardship because hospitals are not taking in those patients who don't have these emergency conditions right now, and as a result, they're foregoing a lot of revenue. In fact, the estimates are that over a 1 month period, our members are sacrificing about $600 million in revenue in order to make all of these accommodations to create that bed space and that bed capacity for patient need. And so that's a financial and economic hardship for our members, but it's also one that they're willing to do because that's part of their community service mission of making sure that they're ready 24/7, 365 to meet the treatment needs of patients in Virginia. And so, right now we have not had a capacity crunch, which is a good thing. There are still beds available to accommodate patients, but as you know, there have been many challenges with this, both in terms of access to personal protective equipment, access to testing. So there are a number of issues that are still challenging. And then the other issue to bear in mind is that while there hasn't been that capacity crunch yet, and our members, along with the state government and the federal government, have all been working together to make sure that we can meet this challenge head on, the expectation is that the peak intensity of infections and potential hospitalizations is still a few weeks off. So, we still have to steel ourselves for the conditions to come. But as you say, right now, our members and all of their dedicated and caring staff have managed this with such compassion and skill. And so that's a credit to them.
Well, let me ask you something about this $600 million. Look, and people don't realize what has happened here. Just to give our audience another breath at this with what Virginia hospitals have done and what they've had to endure. So all elective surgeries got canceled. A lot of those are where there's profit margin. So they've got canceled because what Virginia hospitals wanted to do was the right thing, which is make those 5,800 potential COVID-19 beds and ICU units available. So they cleared all that out. Well, that cost them $600 million. Meantime, 5,000 of those beds are empty. And we've heard of hospitals, Julian, in Virginia where there's mass layoffs of various workers because they don't have the beds filled. There's no work for them to do. They're not getting the revenue in. So then they get laid off. They got to go on unemployment. At what point in time do we say, okay, the models we have are flawed. We're not overrunning our healthcare system. We have 880 people in the hospital for COVID-19. We have 5,800 beds. That's only a 16% ratio. We've got 84% availability. When do we say, okay, it's time to open the government, it's time to open the economy back up and save these small businesses and jobs? Because the whole argument for closing them down and shuttering the economy was that we don't overrun our healthcare system. Well, it's not even close to that. So where's the argument now?
Yeah, so I would say a couple things, John. With respect to sort of reopening the economy, obviously, as you know, that's going to be a decision that comes out of the White House, and then obviously the governors in the various states will have some role in that. But I will tell you that our members who have been forward-looking and proactive throughout this process, are taking all the necessary steps to make sure that, as I said, all the patient treatment needs can get met. At the same time, they are also looking at what's to come. And to your point, when do they look to the restoration of some of these non-emergency procedures? Because that is, not just important for the operational and the functionality of our members, but also for the patients that have other medical needs that are not emergency but are still important to them. I mean, I can use myself as a personal example. A couple months ago, I ruptured my Achilles tendon playing basketball,
right.
And I had a surgical procedure, Achilles tendon repair, prior to the onset of the pandemic, particularly in Virginia and the United States. But if I were in that situation now, I might be someone who might have to hold off on that kind of surgery because there might be other more pressing medical treatment needs that took priority, and appropriately so. So I think all of our members are looking at next steps, both in terms of making sure that we have a handle on this pandemic, making sure that they have all of the resources necessary to respond to this, particularly if there is an uptick or a surge in patients, as infection cases grow. And then also looking, as you said, forwardly to see when we get back to normal. And then the other thing I would say, you brought up some of the furloughs, and I would just point out, I think you used the word widespread. I wouldn't characterize the furloughs as widespread, and your audience should know that those are non-clinical positions. And again, those are decisions that are difficult for hospitals to make, but they're decisions, again, in this unprecedented environment where, they're foregoing significant revenue and at the same time investing significantly more to make sure that they have all the resources in place, whether it's the equipment or frontline clinical staff, all of those folks. They're investing more even at a time when they're sacrificing revenue coming in. So that's some important context there.
Are the hospitals going to get any of this money back in the form of a grant? I know that there's a Phase 4 being worked on. Somebody in the Phase 3 went to hospitals. How is that shaping out?
Well, as you know, the CARES Act had significant funding for healthcare providers, but that's nationwide funding. And at this point, that money hasn't flowed yet. And there will obviously be, as there is with any federal appropriation or state appropriation for that matter, there's a formula to determine how those funds are divvied up. And so and also you should know, and this is not uncommon with federal funds, is that sometimes they come in tranches. They don't come all in one big lump sum. They will come in different distributions at different periods of time. And oftentimes, as I said, there's a formula or there's an application process. So I would say our members are still sorting through that with the support of the association to figure out how to apply and or receive some of that funding to help soften the economic and financial blow. But again, that money has not flowed yet, so there's still a lot to be determined there.
John Fredericks Radio Network. I'm with Julian Walker. He's Vice President of Communications with the VHHA. That's the Virginia Healthcare and Hospital Association. I got a question here texted in from Mike Watson, former House of Delegates member, Newport News Republican. Mike says, would you ask Julian, with a relatively limited number of COVID-19 patients per region, why can't the hospitals work together to group the COVID patients in one hospital, maybe even one wing per region with the other hospitals, and can the other hospitals get back to standard operating procedure?
Well, that's a great question, and good morning to Delegate Watson. I would say that a lot of hospitals have already taken pretty extraordinary steps, and our members cooperate all the time. In fact, you mentioned the data dashboard, and I don't want to go off on a tangent, but I just want to make a connection here. That data dashboard that we published about a week ago, which includes all of the statistics on hospitalizations and ICU and ventilators and bed availability, and we just added yesterday patients who were discharged. That dashboard is populated with information that's supplied by all of our hospital and health system members across the Commonwealth. In addition to that, that dashboard is not the first dashboard that we've published. For many years, VHHA has published interactive, public-facing dashboards for members of the legislature, for the public, for the media, to help understand healthcare, which is very complex. One of the examples of a dashboard is a quality and patient safety scorecard, which shows key safety metrics hospital by hospital across the Commonwealth. And I bring those up to underscore and respond to the question about cooperation. Things like that, those kinds of projects, cooperating on making Virginia the healthiest state in the nation, is exactly what our members do. And I can tell you and tell Delegate Watson that, in fact, our members have been cooperating consistently and extensively throughout this process, on conference calls with hospital leaders across the state, with government officials, to coordinate all of these things, to look at when the state was looking at alternate care sites if we need to set up field hospitals, to look at increasing testing capacity, to look at things like accessing personal protective equipment and testing. Our members are cooperating up and down the board. I'll just give you a couple examples. UVA, because there were some challenges with access to testing, UVA got the necessary federal approvals, and there was some regulatory approval that was necessary to start conducting tests on its own. And you know what UVA has been doing since then? They've been conducting testing for about a dozen, 12, 14 hospitals to help other hospitals because of the access to testing challenge. That's one example. We have a number of other hospitals that have either opened new facilities, retrofitted existing facilities, converted things like dorms, which VCU did, into hospital space. Mary Washington Healthcare in Fredericksburg built a whole field hospital on its campus. They've got a great video on YouTube explaining that. We had Ballad Health in Southwest Virginia, which designated one of its hospitals, Lonesome Pine Hospital in the Wise County area, as specifically for COVID-19 treatment and quarantine. So we've got members doing all kinds of innovative and creative things and working together in all manner of issues related to this pandemic. So I would tell you and your listeners and Delegate Watson that cooperation is happening. Our members are sharing resources, are communicating together. If they've developed the best practice about, accessing equipment or about sterilizing equipment because of the PPE shortage, to be able to sterilize PPE, something that wouldn't normally happen, but is a necessity in this situation. They're sharing all those best practices. So I would just say to your listeners that cooperation is happening throughout the Commonwealth.
Well, that's good to hear, Julian. And what you guys have done has been really remarkable. I think you probably, if you look at the entire Mid-Atlantic region, or you take basically Florida to New York, you've got to really look at what VHH has done, what the hospitals here have done is one of the best jobs, because you're over-prepared, you've got everything you need. Where there to be a spike coming, you've got that well under control, and certainly the hospital system in the Commonwealth is not going to get overrun, not with the number of beds you have, the number of ventilators you've stockpiled, all within reason. And so, the management of this has been stellar. I guess my question is, financially, one of the concerns that we've always had with COPN and other stuff is some of our hospitals in the outlying areas are never really on financial stable footing. How does this affect them? Are we going to see, are any hospitals in rural Virginia at risk financially? How does that work, sir?
Well, John, as you know, even before this COVID-19 pandemic, there have been a number of hospitals in Virginia that have had financial difficulties. We publish numbers every year, which comes from the Virginia Health Information, which is an agency contracted by the state to publish financial information and other data about hospitals on an annualized basis. And so even before COVID-19, just looking at the VHI statistics, we've had a significant number of members, both rural hospitals and non-rural hospitals, urban and suburban hospitals that have experienced financial challenges and have had negative operating margins. And, you know, in the most recent data that we have, which is 2018, you have about 50%, I think it's 53% of rural hospitals that had negative operating margins in 2018, and about 30%, so almost a third of all hospitals in Virginia had negative operating margins, and that's due to a number of things. That's due to the charity care that's built into the system, to the emergency room mandate that requires that people get care regardless of whether they have insurance or can pay. That's due to the Medicaid and Medicare shortfall, which is the difference between what Medicaid and Medicare reimburse for treatment and what it actually costs to provide treatment. As you know, our members are spending substantial sums of money to cover the state share of Medicaid expansion costs. And then there's also that charity care piece I mentioned. In 2018, hospitals provided $714 million in charity care. So there are a lot of financial pressures that exist even outside of COVID-19. And then, as we talked about, by postponing elective surgeries, you still have all of those financial pressures, plus you have the fact that hospitals are foregoing, sacrificing that revenue to create this additional bed space. So those financial challenges exist, and they existed before COVID-19, and they're still present, and perhaps magnified by COVID-19. And then I'll just say quickly, I'm glad you brought up COPN, because this is a really important point, and we've gotten some questions about this recently. Some of the folks who have said, well, you know, if we didn't have COPN, we'd have more hospital beds. And here's the irony of this, that the same folks that want to talk about market forces in healthcare, even though healthcare is not a free market, don't acknowledge the fact that we have the number of hospital beds we have in Virginia precisely because of market forces, because that's the number of beds that the market demands based on patient use and patient occupancy that we have. And furthermore, what people should know is that this situation crystallizes exactly why we need COPN, because all of the people that want to dismantle COPN, those folks aren't the ones that are taking on patients 24/7, 365. Those folks aren't the ones that are freeing up bed space and making financial sacrifice. Those practices aren't the ones that are responding to this COVID-19 pandemic. It's the hospitals that are doing that. And by sacrificing the elective procedures, this underscores exactly what would happen if you did away with Certificate of Public Needs. You're taking away those profitable services that keep hospitals in operation. And so the hospitals are the ones that are on the front lines responding to this, not these other folks that want to do away with COPN. So they can talk about all their theory and everything that they want to discuss, but this situation is a perfect real-world reality example of why COPN is important and why hospitals are unique. And I would just say, if you want to talk about the hospital beds, I would point to Pennsylvania, which is a state that in the mid-'90s did away with COPN. In the 25-plus years since they did away with COPN, they have more than 50 fewer hospitals in Pennsylvania, and they have something like, and I'm not looking at the exact numbers in front of me, but I believe it's more than 10,000 fewer hospital beds in Pennsylvania than they had before COPN was sunset there. So if that's not a perfect crystallization, a perfect case in point to underscore the point that if you get rid of COPN, you're not growing hospital beds, you're not increasing hospitals, you're losing hospitals, you're losing hospital beds.
Exactly. You know what? I've been making this argument for so long. It's such an easy argument to make. That's why we have COPN, because it's a regulated system to begin with. As long as you can walk into an emergency room and get care and be charged nothing, it's not an open free market system. Hospitals have to be on the same field as everybody else. But again, it gets back to managing this, and I think you guys have done a fabulous job. Hey, Julian, we're out of time. I really want to thank you for being with us today and sharing that outstanding job that VHHA is doing, the Virginia Hospital and Healthcare Association, and all the hospitals in Virginia. Remember, 5,800 beds available for COVID-19. Currently, about 850 people hospitalized, at least 5,000 beds open. So even with a spike, we're in really, really good shape here. Let's hope that doesn't happen, and let's hope we don't need the beds.
Thank you so much, John. Really appreciate it. And we'll just encourage your listeners to visit our website at www.vhha.com. They can look at our dashboard, which is right there on the front page. There's a link to it. And if people have supplies they want to donate to help out hospitals, under the COVID-19 update tab, which is also right there on the front page, they can find a link to do that as well.